Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Use of radioactive iodine therapy in thyroid cancer, special considerations for the pediatric population. No disclosures from the author. Pediatric differentiated thyroid cancer is rare, incidence of 12.4 cases per million patients. Phenotypically, it's very different from adult DTC. In children ages less than 14 years compared to teenagers and young adults, it also presents differently. Pediatric DTC more readily presents with widespread nodal metastatic disease to the neck and metastatic disease to the lungs than adult counterparts. However, with surgery, radioactive iodine, and TSH suppression on hormone replacement, it's recognized that there are good long-term outcomes. For example, in a retrospective study of 112 pediatric thyroid cancer patients, the 20-year survival was 100%, and this fell to 94% at 30 years. Progression-free survival at 10, 20, and 30 years was 71%, 62%, and 55% respectively. Similarly, in a smaller study of 45 patients, there was 100% survival at 5 and 10 years and slightly lower progression-free survival. The protocol for pediatric thyroid cancer at University of Michigan, following total thyroidectomy, patients undergo 4 weeks of thyroid hormone withdrawal, bridged with cytomel, which is stopped 2 weeks prior, and then they come in for their radioiodine imaging. After a 2-week low iodine diet, labs are drawn for beta-HCG in women of childbearing age. TSH should be more than 30, and thyroglobulin levels are drawn. Then, based on risk stratification, either no iodine is given, low dose 30 to 50 millicuries, medium dose 100 to 150 millicuries, or high dose 200 to 300 millicuries. The intended activity dose of radioactive iodine is body weight adjusted with a minimum of 30 millicuries adjusted to a maximum of 70 kilograms. And the benefits and precautions are discussed with the patient and their parents. The imaging protocol consists of a diagnostic pre-ablation I131 scan and then whole body sweep with static images of the neck, chest, and SPECT-CT. And we do whole body retentions at 48 hours, as well as the option for full dosimetry. So the first case is a 22-year-old male with thyroid cancer. Neck CT showed a large enhancing heterogeneous right lower thyroid mass, consistent with PTC, and enlarged right level 2 and 3 cervical lymph nodes, as well as lymph nodes in the thoracic inlet. Chest X-ray did show bilateral lung nodules. There was no personal history of radiation exposure. The axial images of the contrast-enhanced neck CT show enlarged lymph nodes in the right neck, as well as a large right thyroid nodule. The coronal and sagittal views show these enlarged lymph nodes in the right neck predominantly. He had total thyroidectomy and right neck dissection. He had a 3.9 centimeter multifocal PTC in the right lobe. There was lymphatic invasion, negative surgical margins, and 21 out of 83 lymph nodes in the right neck were positive for metastatic disease. Largest deposit was 4 centimeters. He underwent hypothyroid protocol. However, he had to be switched to thyrogen I131 imaging because the TSH of 7.6 at the time of planned imaging would not rise. This was because it was suspected he had functional metastasis in the lungs. His thyroglobulin was elevated at 183 mg per ml with no antibodies. These are the whole body and static images showing intense uptake in the central neck. There is a little focus at the left upper neck, and you have a septal penetration star artifact present. There is some vague haziness in the lungs. A SPECT-CT was performed showing persistent right paratracheal iodine-avid lymph node in the neck, as well as multiple iodine-avid bilateral lung nodules consistent with lung metastases. The lung fraction as a percentage of the total was 15.5%. He was administered 200 millicuries I131, which is a high dose for treating distant metastatic disease. The whole body estimated dose to bone marrow based on whole body was 0.21 centigrade per millicurie, and to blood was 0.32 centigrade per millicurie, meaning that he could have received 600 millicuries in theory to be less than the 2 gray exposure to the blood when toxicities are encountered. At the post-therapy scan, he was quite symptomatic from the radioactive iodine. He had myalgia, fatigue, swelling of the neck, dehydration, and nausea. His tongue was dry and he had a sallow complexion. He was started on levothyroxine, 200 micrograms times 8 per day, and given Zofran, Compazine, omeprazole for gastritis, prednisone for the swelling related to radiation-induced edema, and encouraged to increase his oral fluid intake. At the 2-month follow-up, his thyroglobulin had responded with a TG falling from 183 down to 0.3 ng per ml. This is the post-therapy scan showing excellent targeting of the iodine-avid regional disease in the neck and bilateral multifocal lung metastases. The second case is a 13-year-old female who had COVID 2 years ago and had been diagnosed with thyroid nodules. The FNAB was inconclusive on 2 occasions, consistent with follicular lesion of unknown significance. This is also called atypical lesions of unknown significance by the Bethesda system. She has a history of Hashimoto's thyroiditis and a family history of thyroid autoimmune disorders. Surgical pathology showed resection of a 1.2 centimeter multifocal PTC in the right lobe. There was lymphatic invasion, negative surgical margins, and 0 out of 2 lymph nodes involved, i.e. they were both benign. There were some incidental oncocytic adenomas that were benign as well. She underwent hypothyroid protocol. Her main symptom was fatigue from the hypothyroidism with a elevated TSH greater than 150, low free T4, and the thyroglobulin was only 0.2 ng per milliliter, which is just at detectability range. Beta HCG was negative. Her whole body scan and static images of the neck and chest showed very faint uptake in the central neck compartment, and that was consistent with remnant tissue only. So she has low ATA risk of recurrence. It's only a 1.2 cm encapsulated PTC, no lymph node spread. TG is only 0.2 with a TSH of greater than 150, which is excellent stimulation. So the recommendation was to forgo radioactive iodine therapy, and the patient and her mother were agreeable to this plan. She was referred to pediatric endocrinology for long-term follow-up with neck ultrasound and lab training. The analysis of SEER database shows that in pediatric patients, the percentage of patients treated with RAI increased from 4% in 1973 to 62% in 2008. And then there was a reversal of this trend between 2000 to 2018. In 2009, 59% of pediatric thyroid cancer received RAI, but by 2018, only 11% received radioactive iodine. And this is largely a consequence of the ATA pediatric guidelines that were published around 2015. Also, in that same time frame, radioactive iodine dose administration has declined on average from 80 millicuries to 42 millicuries, and only half of low risk and all of intermediate and high risk patients continue to receive radioactive iodine. So in conclusion, these 2 cases demonstrate the heterogeneity of presentations, ATA risk of recurrence, and radioactive iodine dose prescriptions for pediatric thyroid cancer. These 2 cases are ranged from 200 to 0 millicuries of I1 through 1. The doses are weight adjusted to body weight. SPECT-CT, ATA risk stratification, and dynamic risk stratification is crucial to select the correct RAI activity and balance the effectiveness of treatment with side effects. This will allow us to more correctly understand the use of RAI in pediatric thyroid cancer. In our experience at Michigan, rarely are more than 2 RAI treatments beneficial or delivered. And the goal of care in pediatric patients with M1 pulmonary metastatic disease is not to achieve no evidence of disease, because even in treated patients, there is persistent structural disease. However, this remains very inactive and patients have excellent outcomes. But they do need to be followed by pediatric endocrinology to recognize the occasional cases where disease becomes active and is progressive, and those cases where it could affect the overall survival. Thank you.